All right, thank you very much for the invitation. As alluded to earlier, I'm sometimes the whack-a-mole in the whack-a-mole of liver tumors. My name is Amol Mujoomdar from Western University in London. And I'm going to talk a little bit today about interventional radiology therapies for neuroendocrine cancer. These are my disclosures, some of which are slightly relevant for some ablation technology and for Y90. So I just wanted to talk a little bit about what's the role of the diagnostic and interventional radiologist. I don't have as good PR as some of the other specialists, the surgeons, the oncologists kind of conjure up a lot of images for patients. Sometimes when people come to see me, they say, you're the interventional radiologist, doesn't conjure up a lot of imagery, what exactly I do. So I'll just kind of go over a little bit, but we do have a role to play on the neuroendocrine team. And talk a little bit about the different type of therapies we do, mainly for liver metastases, ablation therapy, as well as a lot of the transarterial therapies. We'll talk a little bit about the patient experience and what are the risks or side effects of these therapies. So the radiologist kind of has a role in the background. Many of my diagnostic colleagues are reading your scans along with the nuclear medicine docs and kind of looking and hopefully detecting things early and picking up the different lesions. I do that to a smaller degree, but I mostly do the interventional side where we use this imaging to do different types of procedures. And whether it's live x-rays, ultrasound, or CT guidance to do these types of procedures, and that's the interventional radiologist. I mentioned a little bit, sometimes you meet a radiologist early on in the journey, and that's really to just do the biopsy. And that's, a lot of times how we diagnose this condition is with a liver biopsy. And then you may meet us later on when we're doing things like ablations or any of the transarterial therapies. And, for people with higher grade disease that need venous access for chemotherapy, we're typically involved in some of those type of procedures, portacasts, PICC lines, and things like that. So anytime we're talking about cancer therapy, we always want to talk about what are our goals of care, right? Because as mentioned, there are different types of therapies that people will encounter at some point in their journey. And really from the IR side of things, these are typically palliative type of therapies or non-curative therapies most of the time. Some of the time we're trying to control people's symptoms in people that have carcinoid syndrome or some of the more functional tumors. And we're really trying to prevent some of the complications of those functional tumors with heart valve disease and things like that. Sometimes we're trying to help out the surgeons. If we see someone that has disease that's potentially can get an operation, we'll try to shrink it a little bit or try to do some type of procedures to really help the liver surgeons, beef up the liver so that they can go and potentially have a curative resection. And then occasionally, if you have very small disease that we can go and zap in the liver, it can be curative, but we know that at some point, typically over the course of people's journey, they may develop new lesions. So I'll talk a little bit about ablation. Ablation is not something we commonly do, but I wouldn't say it's terribly uncommon in neuroendocrine, but it tends to be more of the arterial therapies. It's a minimally invasive therapy. Okay, that's really if we think what are our goals of doing an ablation, well, we want to really destroy a tumor, okay, and have a margin much similar to what a surgeon would have, without really destroying the vital tissues. And we also ideally would like to improve survival. So we really have two main technologies, and there's different ways of kind of barbecuing the liver is really with RFA or microwave. There are other types of technologies that exist, something called cryoablation. We don't really use in the liver very much, and a newer technology, IRE, but your taxes will go up significantly if we start doing a lot of IRE. This is kind of, what just an image or a what really it looks like. We tend to use a lot of ultrasound, sometimes CT, and we really just put an ultrasound probe on a patient, and we try to find that liver tumor that was detected on the MRI or the CT. And once we kind of see it, we sort of, shish kebab it basically and cook it. And really trying to plan that therapy with how big the tumor is and choosing the right tools to kind of burn it. It's typically an outpatient type of procedure. And this is kind of an example of, and I promise we don't have a pointer, but I hope people can see in the very back, there's kind of a vertical black structure in the very back of the screen. There's a white line, and you can kind of imagine a circle, a tumor there in the back. And if you could just play the video there, that's a liver tumor that you'll see in a second. Does the video work? Okay, well, another video bites the dust, okay. Funny, they all work back there, but not up here, okay. Probably better you don't see it anyway. Okay, no, it typically just looks like a white ball of gas that forms around the tumor, and it's not predictive, but certainly it's helpful for us when we're treating to ensure that we're dead center in the tumor and that we've planned the geometry of the treatment, and that's typically our kind of skill or shtick as an interventional radiologist, is to really target that tumor precisely so that we can burn it completely. So what's the patient experience for all this? Well, usually for an ablation, it's an outpatient procedure. Patients come through kind of an area where they're prepped and recovered, where they get an IV, and we use that IV to sedate people. In some centers, they'll do a general anesthetic, but in our center, we typically use what we call moderate sedation, similar to a colonoscopy. The burning obviously can be uncomfortable, so that's the part we typically give the double shot tequila or something good through the IV. And usually we keep people for a few hours afterwards to observe them, much similar to a biopsy, and they go home after a few hours of observation. And then we tend to see them back in our clinic in 3 to 4 weeks with imaging and sometimes with blood work, depending if we're following the chromogranin A or if they have functional tumors. The risks are surprisingly fairly low with this procedure. There are some risks, though. People can bleed. We occasionally will see infection. And the big risk is we worry about collateral damage. We are burning the tumor, but we are going to burn some normal liver. We don't worry too much because, as we've already kind of discussed, the liver does have this really amazing regenerative capacity, but we don't want to burn normal structures either in the liver or outside, things like main bile ducts. We don't want to burn the bowel at all because we turn a minimally invasive procedure into a maximally invasive procedure. But in reality, if we plan things properly, the risks are relatively rare. Who do we really treat with ablation? Well, ideally we would treat people that have very few liver lesions, that are small in size and amenable to treatment. We obviously work in a multidisciplinary environment, and we really do try to evaluate patients if they're a candidate for surgery, because even though in the neuroendocrine world, I don't know if we really have data to say that surgery is better than ablation in all comers, but we certainly will push people if they're candidates to have surgery, because surgery ideally will debulk and achieve potentially longer-term disease-free outcomes. But sometimes, rarely, we'll do a debulking type of ablation where we may not get the entire lesion, but in someone with functional disease, just to really try and decrease the disease burden. But this is a less common disease treatment modality for people with neuroendocrine cancer because they typically present with disease that's kind of outside what we would say are candidates for ablation. They typically present with usually multiple liver lesions, and we tend to be thinking more about the arterial therapies, which we'll talk about. So the different types of arterial therapies exist, and why do we do this? Okay, so that we get away with this in the liver. The liver is kind of a unique organ, has a double blood supply. It has a big vein that really feeds the bulk of the liver, the portal vein, and it has an artery that kind of feeds the minority of the liver, but it tends to be preferentially feeding tumors. So normally if I take any of your other organs and if I take your kidney and I just blast the artery with anything, I'm going to kill either the entire kidney or a big chunk of the kidney. But when we do this in the liver, we tend to ideally feed the liver either with poison, which would be chemotherapy, or we feed it with some type of particles or with radiation beads, but with kind of sparing the normal liver and not killing it. Because it has a double blood supply, then the vein would kind of take over feeding. So instead of a 80-20 feeding, it would kind of fill the gap. So this kind of is a bit of a diagram showing, the bottom right picture is an angiogram. That's what an angiogram looks like. People get angiograms of the heart. Just like you get an angiogram of the heart, we can certainly do an angiogram of the liver and really map out. And you can see that sort of ball-like structure, which is the tumor. And you see in this sort of diagram the catheter that's kind of snaking through a lot of times the groin. But we've really migrated to doing these a lot through the wrist now because it's a little bit more of a comfortable procedure for patients. And really snaking right up to these feeders of the tumor and to kind of blast it. So different centers will do things differently. Certainly a lot of centers will do what's called bland embolization, where they take these plastic shavings, mix them up with some X-ray dye, and inject them into the tumor. At our center, we tend to do more chemoembolization, where we mix chemo with a poppy seed oil derivative, inject it into the tumors. That way, either way, we want to see where it's going. That's, once again, we like the imaging, the live X-rays to see what's being fed. And then in the chemoembolization, we tend to also block it. So you're either kind of choking it or starving it of its blood supply, or you feed it the poison first and then choke it and starve it of its blood supply. We tend to use, no matter if you're doing chemoembolization, everybody uses the same chemo, doxorubicin. It's kind of been around for a long time and not really used systemically for neuroendocrine cancer, but it tends to work for whatever reason in the arterial therapies. And typically, and everybody does this differently, some centers will do this as an outpatient procedure. We do it as an admission to hospital. We tend to admit people the night before, kind of get them ready and optimized, do it the next day, and then people will tend to go home the day after. And we do it, obviously, in the interventional radiology suite with live x-rays. I usually tell patients the day of the procedure is not a great day. We try to anticipate some of the symptoms. People typically will feel kind of sick, like you feel flu-like symptoms. So we try to anticipate that and load them up with some medications for nausea and a little shot for pain before we touch them. But, it's usually a rough day, and you're not going to be ordering the steak dinner in the hospital, that's for sure. Usually people don't feel that great, but usually by the next day, you start to feel better, and then, you go home, and you're not going to feel like 100%. I would say fatigue is kind of the overwhelming thing that most people will tell you that they feel after a chemoembolization, but 9 times out of 10, people will certainly bounce back after kind of 2 to 3 weeks of feeling pretty crummy. So we mentioned, how does this work on tumor? When we do bland embolization, we're really just starving the tumor of its blood supply. And we mentioned with the chemotherapy itself is directly kind of toxic to the tumor cells, as well as by starving it of its blood supply. People will ask, okay, why do you do 2 different types of techniques? Why don't you just pick one? Well, people have looked at that in the literature, and really, I would tell you it's a bit of a wash in the literature whether you should do chemoembolization or whether you should do bland embolization. From a tumor effect or a treatment effect, it's pretty much the same. From a patient how do patients tolerate this? It's pretty much the same. So it tends to be more of a center-specific approach. So, and I think that's the best way to kind of summarize it. And really on what your interventional radiologist or your neuroendocrine multidisciplinary team has expertise in doing. So we kind of mentioned the patient experience. It's a bit different because it's not an outpatient procedure like an ablation. Most people are admitted to hospital. Usually the procedure itself is well tolerated, but it is a bit rough that day of the procedure. When people go home, we tend to give them, medications to help them out, to anticipate things like nausea, mild pain. But I would describe it usually the next few days is kind of like a mild flu-like symptoms. You can be nauseous, and you can have low-grade fevers, you can have pain, and be tired. And we do see some chemo side effects, not commonly, but it's not uncommon that people will have some systemic side effects, so they may lose a bit of hair, and we do see some changes in their blood work as well related to the chemotherapy. We'll talk a little bit about Y90. I love talking about Y90, but I also hate talking about Y90 because, it's one of these therapies that would be really great to offer to patients, but unfortunately it's not funded in most provinces. It's funded through this national conference, so if you happen to live in I think Alberta and BC, you can typically have neuroendocrine tumors treated with Y90. I think PEI and New Brunswick as well in Halifax, but in Nova Scotia I don't believe it's funded, or is that incorrect? Oh, perfect. So there you go. So now another one bites the dust. Nova Scotia's in. So hopefully this is something that's being discussed in Ontario, and we're hoping not that everybody would get Y90, but to at least to offer it to patients in certain indications, people that don't respond to chemoembolization, people that don't tolerate chemoembolization would be a great option. So what is Y90? Y90 is a therapy that we basically deliver radiation to tumors. And so why would we want to do that? Well, we know that radiation can be very lethal to cancer cells if you deliver it in a sufficient dose, okay? And the Y90 technology is these very tiny, either glass or resin spheres that have Y90 either impregnated into them or on the surface, and it'll sort of go inside the tumor blood supply, sit in the tumor, and emit a very high point source of radiation, okay? And ideally, because the tumors tend to be vascular, it will localize within tumors and spare the normal liver. And therefore, you can really deliver a high dose of radiation. It's a very high beta energy emitter, which on the electromagnetic spectrum, that's one of the highest kind of energies that we can achieve, and it's over a very short range, so only 2.5 millimeters, a maximum range of about 11. The half-life is fairly short, it's about 2.5 days, and it will stabilize to a very stable radioisotope. And it's been around for quite a while, since 1991, and it's also approved in the States, in Europe, and used quite commonly in different centers. And that's just kind of a diagram showing the Y90 sitting in the tumor and the catheter kind of delivering it through the blood vessels. What's the patient experience with Y90? Well, it's pretty similar, but the only difference is really an outpatient procedure. And it involves kind of two separate procedures. We do a planning day where you have to kind of bring someone in, do an angiogram of the liver, and really map out the blood supply of the tumor. And you're kind of predicting. You really don't want any glass or any radiation spheres to end up in the gut. That's a terrible and horrible kind of side effect or complication of the procedure. We don't see it very commonly at all. In fact, touch wood, I've never seen it in my practice, but we don't want to see it because it is very devastating. So we really have to plan and prepare. And then we bring them back a week or two later for Y90. And really people recover for a couple hours and they go home. The risks are very similar. There's only a couple of extra risks that are related to Y90, and that's really the rare complication of ulcers and putting people into liver failure. That would also be quite rare in the setting of a neuroendocrine cancer, but if you treat someone's whole liver, you don't want to get them in trouble, and a radiation-induced liver disease. The side effects are, I don't want to go through each individual side effect, but I will tell you that it's a much better tolerated procedure from a side effect profile compared to the chemoembolization. But fatigue would also be the most common thing. And then really people have to have certain precautions. This sits in your liver, it's not in your urine, your stools, you don't have to worry about going to the bathroom, you're not a danger to society, but we keep some certain precautions to say, a few days you don't sleep in the same bed as your partner, to no close contact with children or pregnant women for a week. Really, those are precautions. In terms of efficacy, it's really been kind of looked at, and it's basically the same kind of thing. It's very similar treatment efficacy compared to bland taste and chemoembolization. There's kind of really no head-to-head trial. There's a trial out of UPenn that's looking at different types of embolization. Really, the advantage is that it's good side effect profile, and it's generally a painless procedure, but the disadvantage is the cost. The Y90 is about 15 grand, which in the oncology world, that's actually cheap, but in the interventional radiology world, that's very expensive. It's not funded, and you can really only do it once or twice, whereas I could do chemoembolization forever because the liver has a radiation threshold, so you can't do this unlimited number of times. And how do we determine who are a candidate for these therapies? Once again, we discuss these at the tumor boards. We are typically picking patients with low or intermediate grade disease. People with high grade disease tend to be more candidates for chemotherapy. So a lot of times the biology will indicate where we're going. And this is something that we do at different points in people's journey for neuroendocrine cancer. So we kind of talked about this low or intermediate grade disease, people with liver-only disease or liver-predominant disease. If you have functional disease, that could be plus or minus disease outside the liver. And really, what are our goals of care? We want to make people live longer with good quality of life. We want to prevent disease progression and improve a lot of the patient's symptoms related to the carcinoid syndrome and protect the heart. So in conclusion, the interventional radiology therapies that we talked about are common and effective for treatment of liver disease in patients with neuroendocrine cancer. We have different indications, but most of the procedures we do tend to be for disease control and symptom management and rarely for curative. And there's really no difference between bland, chemo, and Y90 except for really the side effect profile. And ultimately, the group of docs at everybody's institution sit down and make these decisions together, really putting the patient at the center and figuring out the best treatment plan. Thank you.